Let's summarize and revise the important points from this guideline. So when is the emergency contraception indicated? It is indicated in any patient or any women who wants to avoid pregnancy if she has unprotected intercourse on any day of a natural menstrual cycle. Remember, we have different days when the women have undergone some kind of procedure or had a childbirth. So in those cases, if the patient has got childbirth for 21 days, she is considered to be at a very less risk of pregnancy, but from 21 days onwards, if she has got unprotected intercourse, she needs to have emergency contraception so as to avoid pregnancy. But if she is following all the lactational criteria to meet the lactational amenorrhea criteria, then in those cases, she is at a very less risk of pregnancy because even that works as a contraceptive. So if she is exclusively breastfeeding, she is not having period, lactational amenorrhea can really work as a contraceptive for around 6 months, right? Whereas in cases if a woman has had abortion or miscarriage, ectopic pregnancy, or uterine evacuation for gestational trophoblastic disease, then she is at risk of having pregnancy from day 5 onwards itself, right? So she needs to have emergency contraception from day 5 onwards. Whereas on the other days, if the woman who is on regular contraception and she misses her period, she misses her contraceptive pills, then she needs to take this emergency contraception to prevent a pregnancy. So if she uses her regular contraception incorrectly or misses pills, she needs to take emergency contraception. So these are the indications where EC is required. You remember that on the days of ovulation, on the day of ovulation, as well as on the days prior to ovulation, the pregnancy risk altogether remains around 30% from a single episode of unprotected intercourse. Whereas if there has been an episode of unprotected intercourse once in a cycle, then there is 25% chance that it has happened in the fertile period. So that is why, so as to avoid any chance of being pregnant, the GDG has recommended to give EC to any patient who has got unprotected intercourse on any day of the natural cycle. Okay, so the choice of EC will of course depend on how near it was to the fertile period. Okay, now there are this emergency contraceptive providers who provide the contraception at different levels in the community, and there are some instructions that are given to them that if a woman approaches you for emergency contraception and you don't have that emergency contraception with you available, you cannot just send the patient back, but then you need to give her the information regarding all the other methods. You need to signpost these women to the services that can provide emergency contraception. And suppose the patient has come for copper T and you don't have copper IUD, then you need to give her oral EC, but do not deny the emergency contraception, or don't just refer because you are delaying the emergency contraception, which can increase the risk of pregnancy, specifically in such cases, right? So this is one of the responsibility of emergency contraception, contraceptive providers, to give all the information related to all the types of emergency contraceptives. And they also need to tell the patient that these oral emergency contraceptives are not the regular contraceptives, and if they have another episode of unprotected intercourse later on in the same month, these are not going to be useful, right? So they need to take this emergency contraceptive again, this pills again, okay, oral emergency. Of course, if they if the women have opted for copper IUD, that will provide ongoing contraception. Now, how does this EC work? Now, remember, the sperms are viable for around 5 days inside the female genital tract, right? And if the ovulation occurs in those 5 days, then there will be fertilization and pregnancy. Now, the copper T, the copper IUD, has got copper in it, which is effective, which is toxic for sperm and ova. And because of this toxic effect on sperm and ova, it will affect the motility and viability of the sperm and the viability and the transport of the ova, thus preventing fertilization. Say, for example, if the fertilization has already occurred, then as copper IUD is a foreign substance, there is a foreign body there. This will cause a local endometrial inflammatory reaction, resulting in the prevention of implantation. That is how it works in pre as well as in the post fertilization periods to prevent the pregnancy. Whereas UPA-EC, that is ulipristal acetate, used in the dose of 30 milligrams, is a selective progesterone receptor modulator, acts by delaying the ovulation for at least 5 days, okay, until the sperm from the unprotected intercourse for which the EC was taken is now no longer viable, right? So it delays ovulation. But remember, this UPA-EC is considered to be more stronger and more effective than LNG because it works even after the start of LH surge. Of course, it cannot work or it cannot inhibit ovulation once the peak, LH peak has occurred, right? But it can still work until the LH surge, and that is why it is considered to be more effective than LNG, right? Now, LNG again inhibits ovulation, it delays and prevents the follicular rupture, causes luteal dysfunction, right? But it cannot work once the LH surge has started. It again delays the ovulation by 5 days. But remember that in the late follicular phase, LNG-EC becomes ineffective while ulipristal is still able to delay the ovulation, and that is how the unprotected intercourse, the time of unprotected intercourse, we need to know when it has occurred, whether it was very much in the late follicular phase to decide the drug of choice. And that is why ulipristal is considered to be better if the patient doesn't have any contraindication to ulipristal than LNG. Now, how effective are these methods? We know that copper IUD is the most effective method. It has got least complications. Now, ulipristal has been demonstrated to be effective for EC for up to 120 hours. That is around 5 days. Of course, you need to remember it in hours because these hours are very specific. So you need to know when the unprotected intercourse has happened. So the approximate time should be noted so as to calculate the number of hours. In the same way, remember that LNG is licensed. It is written licensed for EC for up to 72 hours, but it is effective up to 96 hours. After 96 hours, it is ineffective, right? So UPA-EC is more effective than LNG-EC, and oral EC administered after ovulation is ineffective. Now remember, there are a few points which have been mentioned in this guideline that are different from the previous one, and these are updates, and this again is update on BMI, and is a very potential question for the exam because it's a new thing. So remember, there is now a change that BMI, when it is more than 26 or to these patients. If that is not acceptable, give UPAC. If that is not acceptable, give double dose, that is 3 milligrams of LNG. Remember once, whether effective or not for such a weight, right? There are number of drugs which are considered enzyme inducing. So if they're enzyme inducing drugs, they are again going to affect the effectiveness of UPAC and LNG. Of course, it will not affect the copper IUD because there is no hormone working there. So these are going to get reduced, but remember, ulipristal is not to be given in any patient who is using enzyme inducing drugs because we cannot give it in double dose. It has its own side effects, and that is why only copper IUD and 3 milligrams. Again, double dose of LNG is to be considered in patients who are taking enzyme inducing drugs. Okay. Again, we know one thing, that ulipristal acetate, the the effectiveness of this ulipristal acetate will get reduced if there was any hormone that was taken around 5 days after taking ulipristal or 7 days before taking ulipristal. So, for example, a patient is taking Menopil and she took her last Menopil 6 days before. Then she, whenever, if you're giving ulipristal to this patient, then the efficacy will be reduced, the risk of pregnancy gets increased. And that is why you should avoid giving ulipristal to this patient. Also avoid giving progesterone for around 5 days after you have given ulipristal to this patient. So from 7 days before to 5 days after. Okay. So from 7 days before to 5 days after taking ulipristal, you cannot give progesterone. Okay. And if progesterone has already been taken, change the oral EC to LNG, because LNG is not supposed to affect the effectiveness of LNG is not supposed to get affected because of any progestogen, because itself is a progesterone. Now, HIV post-exposure prophylaxis, the Truvada regimen that we use, that is tenofovir, emtricitabine, raltegravir, they are not considered enzyme inducing, so they will not change effectiveness of the oral ED, and the oral ECs in patients who are taking HIV post-exposure prophylaxis. Now, in the previous guidelines, it was mentioned that patients who take drugs that increase the gastric pH, like esomeprazole or pantoprazole, then the effectiveness are not. And we know about ulipristal that from a week prior after taking ulipristal, we should not give any. Okay, so are there any contraindications or restrictions to use of EC? So for copper T, we know that the same contraindications that are there for any other patient, like uh, in patients who have had childbirth between 48 hours to 28 days. So between that period, right? Also, in patients who have got vaginal infection, we give treatment first. The antibiotic treatment should be given so as to avoid any ascending infection causing PID because of copper IUD, right? So remember that the risk of STI, previous ectopic pregnancy, young age, nullipara, they are not the contraindications to use copper IUD. Okay. Now for ulipristal, it is not used for patients who have got severe asthma. So remember, the severe is very, very, very important here, because in severe asthma we use oral glucocorticoid and it has got anti-glucocorticoid effect, right? So that is why it shouldn't be used in severe asthma patients. And all this uh, emergency contraceptive drugs, these oral medicines, they contain lactose. So you need to tell the patient who have got lactose intolerance about the side effects of nausea and vomiting that can happen in these patients before giving them this oral contraceptive. Now, are there any specific considerations for women who are breastfeeding and require EC? Now, we know that softer uterus, and that is why there is a relatively higher risk of uterine perforation during the breastfeeding time, right? However, the total risk or the absolute risk is low, right? But you need to inform the patient about this before putting a copper IUD. There is a specific mention about ulipristal in breastfeeding women, and it shouldn't be given to breastfeeding women, or the breastfeeding women should be advised not to breastfeed for at least 1 week or express or they have been given ulipristal acetate. So remember this, a very important point. And for LNG, the breastfeeding women, the use of LNG is not going to cause any change, and it can still be used, right? There is no adverse effect on breastfeeding women or their infants because of LNG, right? Now, what are the methods of EC they should be offered to a woman who has had unprotected intercourse and wishes to avoid pregnancy? All women, so that is the most effective method, right? Copper IUD can be inserted up to 5 days after the first unprotected intercourse in a natural menstrual cycle. So we know that it can be given up to 120 hours, or if we don't know if the patient comes after that period, right? Then we need to know whether she is within 5 days of her ovulation. So if she is within 5 days of her ovulation, she can still be given copper IUD. Telling that she has had unprotected intercourse 6 days back. Now she is not a good candidate for copper IUD in either UPA, right? So what are you going to do in this patient? So check what was the day of her ovulation by finding out whether her cycles were regular or not. So if she has got a regular cycle, say for example a 28-day cycle, and then we consider her ovulation day to be around day 14, and if she is in the 16th day of her period, say for example, so in the 16th day of her menstrual cycle, then in that case she falls in the category of within 5 days of her ovulation, and that means that even if the ovulation might have occurred, the implantation generally occurs either on the 5th or the 6th day after the ovulation, right? Mostly on the 6th day of the ovulation. So if the pregnancy has already occurred, or if the fertilization has already occurred, there is still time for it to get implanted. So this copper IUD, if we put in, it will act by its foreign body mechanism and will prevent pregnancy in such patients. So we need to calculate the ovulation day if she comes uh, at the after the day of 5th day of her unprotected intercourse, right? Okay. Now, if copper IUD is not appropriate or not acceptable, women should be advised that oral EC should be taken as soon as possible if there has been unprotected intercourse within the last 5 days. So if that is not there, give oral EC. Now, UPA is considered to be the first line who have unprotected intercourse between 96 to 120 hours, because that's the only oral EC that works in that time. And UPAC is the first line oral EC who had unprotected intercourse within the 5 days if the unprotected intercourse is likely to have taken place during 5 days prior to estimated day of ovulation. So remember that because this this ulipristal works by delaying ovulation. So if there was unprotected intercourse within 5 days, before 5 days of ovulation, before 5 days of ovulation, if there was unprotected intercourse, then this UPA will work very effectively, right? And it will delay the ovulation. Of course, once the ovulation has occurred, and then if you give ulipristal, then it's of no use. Now, adolescent women. Now, if it is considered likely that a young person might not abstain from unprotected intercourse after UPA EC and thereafter commence effective ongoing contraception, use of LNGEC with immediate quick start of contraception may be discussed as an alternative option. So basically, remember that in these adolescent girls, they are very vulnerable to have another episode of unprotected intercourse in the same cycle, maybe in the other cycle. So it is really important to start with the quick start contraception in these patients. And also these girls, they are very vulnerable again, or there is a very high risk that they may forget taking the pills, the daily pills. So that is why we use the long-term contraceptive measures, and mostly implants really work well in adolescent girls. Okay. So that is why whenever we are giving any contraception, any emergency contraception to these girls, and seems that they are not going to, if they have an attitude that uh, we feel that they are not going to abstain themselves from unprotected intercourse, because if we start them with ulipristal, then ulipristal we cannot give anything for 5 more days, right? Because ulipristal uh, can reduce the efficacy of other drugs if given for 5 more days, and its own efficacy also gets reduced. That is why we cannot start them with quick start contraception immediately from the next day. So, but that can happen with LNG, and so it is preferred to give LNG to these patients who do not seem to abstain from sex, and then start with a quick start contraception by just putting an implant on the same day. That really is a good option for these patients, is what they are saying, right? But of course, if the unprotected intercourse has occurred before, within 5 days before the ovulation, then UPA is considered to be the first line. And if you find that the adolescent is uh, able to understand the risk of pregnancy, then, and she's able to, she seems to be someone who will take your advice to abstain from sex or use extra precautions the until 5 days when we start the quick start contraception, then again ulipristal can be given to the patient. Right? Now, for patients who are perimenopausal, who are less than 50 years of age, remember that if there is amenorrhea, then they may ovulate at any point of time. So there is no guarantee in patients who are less than 50 years that they will not ovulate after a certain period of time. So that is why you need to continue contraception for 2 years after 2 years of natural amenorrhea for which no other cause is identified. So you have to give contraception for 2 years in less than 50 years. For more than 50 years, of course, it's considered to be more menopausal, but for 1 year until the patient has got proper amenorrhea, for 1 year, you need to continue the contraception because the patient can ovulate and become pregnant at any point of time. Of course, there is, you don't know when the ovulation can occur in women who are less than 45 years and have amenorrhea. In these patients who are perimenopausal and who are taking HRT, uh, because in these patients we cannot give them, uh, we just cannot leave them with all the menopausal symptoms. We start either with the hormonal contraception or we give them sequential HRT, right? So this HRT or is not going to be useful as contraception. Okay, so remember that thing, that if the patient opts for HRT for her postmenopausal symptoms or her uh, or her this symptoms of, sorry guys, so those patients who have got these symptoms um of the menopausal phase, say for example the night sweats, the mood swings, the irritability, right? So in all these patients, you can just use the hormonal contraception because the HRT is not going to provide contraception. Okay. But yes, we know that ulipristal is not really very good with the hormones around it. So that is why if you are using HRT in patients, then uh, ulipristal is not going to be effective, and the concomitant use of contraception or HRT could reduce the effectiveness of ulipristal in these patients, right? Now, going to women requiring EC after sexual assault. Now, whenever the sex occurs forcefully, these patients are at risk of having STI, right? So these patients should be offered copper IUD. Of course, it's not that they shouldn't be given any copper IUD. They should be given an antibiotic cover before putting an emergency copper IUD. And they should be told about all the measures of emergency contraception, so all the methods of emergency contraception. But of course, they should be told that copper IUD is the most effective. It will be giving her ongoing protection against pregnancy and give her antibiotic cover and start with the contraception of copper IUD for these patients, right? Now, orally C can orally C be used if there has also been unprotected intercourse earlier in the cycle? So yes, if there has been unprotected intercourse earlier in the cycle, EC providers can offer a woman an ulipristal or LNG. So because we know that UPA and LNG do not disrupt the existing pregnancy and they are not associated with any fetal abnormality. So remember that even if these are given to these patients and the patient remain pregnant, there is no problems with the fetus that will come up, right? So that is why the GDG recommends that if a woman had unprotected intercourse earlier in the cycle, which were more than 5 days prior to the present emergency contraception, as well as within the last 5 days, and could be at risk of very early pregnancy, then UPA EC can be used, okay? Because even if she remains pregnant in such cases, it is not going to be harmful, okay? And it is also more effective. So use UPA EC. If a woman requiring oral EC for unprotected intercourse in the last 5 days has also had unprotected intercourse more than 21 days ago in the same cycle, now she has had unprotected intercourse more than 21 days ago and now she has missed a period or the periods have been delayed, then of course go for urine pregnancy test, right? So any point of time when the unprotected intercourse has happened previously in the same cycle, you need to keep an eye on whether, because there is a chance of pregnancy from the previous episode, of course you can give her emergency contraceptive pills because the pills are not going to affect the pregnancy if she wants to continue the pregnancy for some reason. And copper T cannot be given to these patients because then copper T with pregnancy, you need to remove the copper T and then remove the pregnancy if she wants to discontinue the pregnancy. Even if she wants to continue the pregnancy, it increases the risk of miscarriage while removing the copper T. That is why copper T is not inserted because of the high chances of pregnancy if she has had a previous unprotected intercourse in the same cycle, right? Now, can oral EC be used more than once in a cycle? So previously it was said that this ulipristal cannot be used for more than once, but now it's been said that if a woman has already taken ulipristal once or more in cycle, they can offer her ulipristal again after the unprotected intercourse in the same cycle. The same with LNGEC, right? But you have to remember about the progesterone formula of 7 days before to 5 days after for ulipristal, avoiding the progesterone, right? So what are the side effects of EC? Remember, there are almost the same side effects like that of other medicines, like headache, nausea, vomiting. They occur in around 30. They occur in around 10% of users, right? There is dysmenorrhea also in some patients. Remember about vomiting, that if they vomit out within 3 hours, this 3 hours is important. So if they vomit out within 3 hours of taking oral EC, a repeat dose should be taken. Again, it increases the risk of ectopic pregnancy and menstrual disturbance. So remember, if after taking the emergency contraceptives, if the menses are getting delayed by more than 7 days, then you need to do a pregnancy test to rule out pregnancy, right? So after oral EC, it's been seen that the periods become little early or within 7 days. What investigations are advised when providing EC? So of course, we need to rule out pregnancy before giving any emergency contraceptive. And before putting a copper T, we need to rule out STI because we don't want to put in any ascending pelvic infection with copper IUD, right? What should women be advised regarding future contraception? For copper IUD, the EC provider should advise women that copper IUD is going to give them ongoing contraception, right? Oral EC, for this, the EC provider should advise the women that oral EC is not going to be any ongoing contraception. And after oral EC, if there is any pregnancy risk, if there is another unprotected intercourse that occurs, because now once you have given this oral EC, it is the ovulation is going to happen some other day, so it is going to, yeah, it is just delaying the ovulation, and whenever that ovulation occurs and if the unprotected intercourse occurs at the same time, there is a risk of pregnancy. After taking LNGEC, women should be advised to start suitable hormonal contraception immediately, right? Because LNG doesn't have any effect on hormonal contraception. Women should be made aware that they must be using condoms or abstain from sex until the contraception becomes effective. Now we know that this contraceptive or the hormonal contraceptions like the combined oral pills or the POPs that we use, they require some time to act, right? So for combined oral pills, and even for that method, we consider progesterone implant and progesterone injectables. They take around 7 days to start working. And POPs, that is mini pills or the progesterone only pills, require only 2 days to start working or showing their effectiveness, right? So for that much period of time, there has to be an extra precaution taken by the patients, that is abstaining from sex or using condom during, if there is a risk of unprotected intercourse during that period of time. Okay. So for LNG EC, you can just start with hormonal contraception immediately, but we know that with ulipristal for 5 days, shouldn't use any other hormonal contraception. It reduces its efficacy. So whatever 5 days plus whatever days that are required for those hormonal contraception to start working, that much days needs to be added to the extra precautions that needs to be taken for those many days, right? Now the GDG advises that CHC, except for Clara, that CHC, MP, DMPA commenced 5 days after administration will be effective after 7 days, right? So 5 days of UPAC plus 7 days of CHC, MP, and DMPA. So all these things are going to take 7 days plus 5 days of UPAC, so that is going to be around 12 days. For POP or the POPs, that it is going to be 2 days, so that is 5 days of ulipristal plus 2 days, that is going to be 7 days. For Clara, it is going to be 9 days, right? So 5 days plus 9 days, so 14 days. So exactly for these many days, you need to take extra precaution if you are giving ulipristal to these patients and then starting with the quick start contraception for these patients, right? So it is currently recommended that LNG IUS should not be inserted unless the pregnancy can be reasonably excluded. So remember, LNG IUS cannot be used for quick start unless the pregnancy is ruled out. And if a woman and her EC provider estimate that unprotected intercourse is unlikely to have occurred during her fertile period, she may consider the option of using LNG-EC with immediate hormonal contraception rather than going for a UPA with delayed hormonal contraception. So whenever there is a less chance that she can be pregnant, start with LNG-EC, right? Because the only reason is it is less effective than UPAC, right? So start with LNG, start with quick start immediately whenever the risk of getting pregnant is less, because we are more concerned about preventing further pregnancies, right? That's our motto, carefree women. Now, what aftercare is recommended in these patients? Uh, Now, whenever we are giving EC, we need to keep an eye on whether the periods come at the right time. So if there is any delay in the period of more than 7 days, you need to do an emergency pregnancy test, of course, in these patients, because there is a very high chance that these patients may be pregnant then, right? If the patient has already had an unprotected intercourse 21 days before in the same cycle, of course, you need to do a pregnancy test in these patients, because then again it increases the chance that it's a very high possibility that the pregnancy has already occurred in this cycle, right? So we need to take these things into consideration after giving oral EC or after giving her emergency contraception. And if a woman is conceived, if now she remains pregnant, then she should be reassured that there is no harmful effect on pregnancy outcomes and no increased risk of congenital abnormality with oral EC. Now, these are few tables which are important to go through. So what are the indications of emergency contraception following the failure of hormonal or intrauterine methods of contraception? Now, you know that the hormonal methods of contraceptions, if they fail, so failure to use any additional contraception for when we are starting, like we said about CHC for 7 days, POPs take 2 days. So if there is any unprotected intercourse in that period, you need to give emergency contraception. In patients who are taking transdermal patch or combined hormonal vaginal ring, so we know that if there is patch detachment for more than 48 hours or if there is a ring-free period for more than 48 hours, okay? So in those cases, that period is the hormone is not working after that 48 hours, and that is why these patients are at risk of having pregnancy and you need to give EC. Now, EC is indicated if the patch detachment or ring removal occurs in week 1, okay? And there has been unprotected intercourse or barrier failure during the hormone-free interval. Now, if during the hormone-free interval or week 1, whenever there is uh, unprotected intercourse, then there is increased risk of pregnancy because the patient is hormone-free for a long time. Now, if this hormone-free interval is extended, then copper T can be inserted up to 13 days from the start of hormone-free interval. So, for example, the hormone-free interval started just before the periods, right? So when we just removed the rings, say for example, 1 week before, now for 1 week there were menses and all, and now we have put in again. Now it can be used for up to 13 days from the first day of hormone-free interval, right? So you can put in the copper T up to that period of time. And about the UPA, we know that if CHC has been used for 7 days prior to EC, the effectiveness of UPAC could theoretically be reduced. And that is why in those cases wherever the CHC has been used 7 days prior and you need to use an emergency contraception, use LNG. Do not use the ulipristal, right? Now for combined oral pills, monophasic containing ethinyl estriol, we know that if you miss a pill or if there has been a pill-free period for a long time, then you need to give emergency contraception if there has been unprotected intercourse. Same thing, like the copper IUD can be given up to 13 days of the starting of the hormone-free interval, and you have to remember about UPA also, right? Now, whenever the patients are using enzyme-inducing drugs, we need to tell them to use additional contraception for 28 days if they are taking combined hormonal contraception or progesterone pill or implant, right? Because this enzyme-inducing drugs can reduce the efficacy of all three of these, and that is why we tell them to use additional contraception for 28 days. Now, if there has been any unprotected intercourse in this period of time, then you need to use emergency contraception, right? Remember, here you cannot use ulipristal because in enzyme-inducing drugs, we do not use ulipristal. So we use either copper T or we use 3 milligrams of LNGC. For progesterone-only pills, if the patient has missed pill for more than 27 hours if she's using a traditional POP, or more than 36 hours if she's using a desogestrel-only pill, then if she has unprotected intercourse in this same time, then she needs to be given emergency contraception. And now if she has resumed to using POP, right? Now again that is going to take, if she, after missing a pill, now when she resumed to taking POP, again it is going to take 2 more days for it to start acting. So even if there is unprotected intercourse in that period of time, she needs to be taking emergency contraceptive, right? Now remember, if she has been taking progesterone oral pill for 7 days before to 5 days after, there shouldn't be any progesterone taken if she is given ulipristal. So try and avoid the ulipristal because there is a chance that progesterone must be taken at least 7 days prior to at least 5 days afterwards. So use LNG maybe in this case, or try to avoid progesterone for this period when you are using ulipristal. For injectable cases, if there is late injection that you have taken for more than 14 weeks, okay, or if there is unprotected intercourse that has occurred in the first week, that is in the first 7 days after the late injection. Now, like if you have not taken the injection for more than 14 weeks and there was unprotected intercourse, or after taking the injection, it takes 7 days for the injections to work and there was unprotected intercourse in the same time, you need to take emergency contraceptive. Okay. Now, copper IUD is only recommended up to 5 days after the first unprotected intercourse that takes place more than 14 weeks after the last DMPA injection. Now, today is the starting of the 14th week of the last DMPA injection, and the unprotected intercourse was 2 days after that. So from 5 days after that is going to be your time of copper IUD, right? Progesterone only implant is also going to work in the same way if there is an expired implant. And for the copper IUD or LNG IUS, you know that when you are removing that, or whenever there is perforation or you cannot find the copper IUDs for at least for 7 days before that, there shouldn't be any unprotected intercourse. If it was, when it is removed or when it cannot be seen, there is a chance that the pregnancy might have occurred. So use unprotected, use oral EC or use emergency contraception in the form of oral EC if there has been severe perforation, or the patient is not willing for copper IUD or LNG IUS for the second time if it was removed, right? Yeah, and you may still use copper IUD or EC in these patients if the patient have had missing IUD, right? In these cases also. So you may use any one of them depending upon the patient's choice. But remember that for 7 days before you you do a removal of copper IUD or LNG IUS, or you find a perforation, if there was unprotected intercourse, you need emergency contraceptive. Okay. Now, the methods of emergency contraception in UK, copper IUD, we know that it needs to be used within 5 days of unprotected intercourse or within 5 days of the earliest estimated date of ovulation. Levonorgestrel is 1.5 milligrams of single oral dose within 72 hours. It is licensed, right? And ulipristal, we have seen that 30 milligram single oral dose progesterone receptor modulator and used licensed for use within 5 days of unprotected intercourse. Now we know about the double dose, that is 3 milligrams of LNG. It is to be used in women who have got BMI of more than 26 and in enzyme inducing drugs, right? Now this is the time that is required for the contraceptives to start showing their efficacy, and 5 days of ulipristal plus whatever days of the efficacy of them to start their efficacy, that much is the time for required for additional contraception, right? Now 5 days when starting 120 hours after the ulipristal acetate, whatever time that is given. So the combined oral contraceptive pill now, and the requirement of additional contraception after the that is started is around 7 days. So we know that for combined oral UC pills, vaginal string, patch, and implant injectable, it is 7 days, whereas for POPs, it is only 2 days. And for Clara, we have seen that it is 9 days of extra precautions. Now, these two tables are very important to remember. If the patient comes to you within 120 hours since the last unprotected intercourse, okay? So if she comes to you within 120 hours, then you need to see whether there was any additional unprotected intercourse which was more than 120 hours in the same cycle. If yes or unknown, then currently less than 5 days after earliest likely date of ovulation or not. So you need to know whether she is in the day of her ovulation or not, because you need to find out whether to give her copper T or oral C. The oral C will not work if the ovulation has already occurred, right? So if yes, if she is within 5 days of her ovulation, then give her copper T. If not acceptable, give her oral C. But if she has already crossed that period or it is unknown, then consider the pregnancy test if unprotected intercourse was extra unprotected intercourse was around 21 days ago, and orally C can be given to this patient. But if you don't know whether the ovulation has occurred or not, then you cannot promise this patient that this will be really very effective, right? So in these cases, you need to tell her that you need to give her orally C, of course. You need to tell her that she needs to have an ongoing contraception along with that, but there is a risk of pregnancy in her. Okay? So whenever you don't know, so if there was a previous intercourse, now you don't know whether she is in her ovulation period or not, and or she has crossed 5 days of her ovulation. From 5 days of her ovulation, which is now more than that, there is a very high risk that she might already be pregnant from her previous episode of unprotected intercourse. There is a very high risk of pregnancy. So give her orally C, because even if she remains pregnant with orally C, it is not going to affect her baby. So give her orally C and do her pregnancy test if she misses a period, and give her a suitable ongoing contraception for the time being, right? So that is the method that you will be using if she is already done with her ovulation and has had a previous episode of unprotected intercourse, right? Now, if there was no unprotected intercourse in the cycle and she has come to you within 120 hours since her last period, okay, then of course you can give her copper IUD, and if not, then give her orally C, right? Now again, if the patient doesn't come to you within the 120 hours of last unprotected intercourse, then check whether she is in the within 5 days of her ovulation. And if she is in the 5 days of her ovulation, we can give her copper T, we can give her orally C, because we can delay ovulation, we can delay fertilization and start with quick start contraception. But if you don't know, then when you don't know that the patient has ovulated or not, or if she has already crossed her ovulation, then there is a chance that she may be pregnant. And in these cases, you can start her with orally C, but you have to tell her that it won't be very much useful for her because the ovulation has already occurred. So tell her that quick start contraception, give her quick start contraception, and tell her that the pregnancy test is very much required. Okay. And if she has already crossed, like now she's more than 5 days, no oral EC is going to be useful for her, right? So that that cannot be offered to her, of course, right? So if she is more than 120 hours of her unprotected intercourse, you cannot give her oral EC. Now, if she doesn't know when was the first unprotected intercourse, like in cases when there has been continuous episodes of unprotected intercourses and the first time when it happened is not known by the patient, then you need to see whether she's within 5 days of her ovulation, and if yes, you can give her copper tea, right? Because until 5 days of her ovulation, you can give her copper tea and you can prevent the pregnancy, right? And of course, you can give her oral EC, but if she doesn't know whether she is in the 5 days of her ovulation or not, okay, then just give her oral EC, offer her oral EC, and suitable ongoing contraception. Okay, so whenever this patient, she doesn't know, there is a doubt that she may be in the first 5 days of her unprotected intercourse, and that is why we need to offer her oral EC. Whereas if the patient knows that it's already been more than 5 days of her unprotected intercourse, and she has also lost the period of ovulation, then oral EC will not work in her, right? And that is why these patients are only given, they are only offered quick start contraception, right? Now let's go to the second one, which tells which one to use, whether to use LNG or to use ulipristal. Now, we know that copper T is the most effective, but if the patient doesn't want to go for it, then we need to see whether the unprotected intercourse occurred within the last 96 hours, right? If it occurred in the last 96 hours, yes, then see whether the unprotected intercourse is likely to have taken place within less than 5 days prior to the day of ovulation. So if it was less than 5 days prior to the day of ovulation, then if when we give this ulipristal, it is going to delay the ovulation, so that is going to be very useful in these patients. So if it is yes, then give her ulipristal acetate and start her with contraception after 5 days. Reconsider copper IUD in these patients if she wants to take copper IUD, because it is going to be more effective. And if UPA is not suitable, like says on enzyme inducing drugs, then give her LNG EC, right? With immediate quick start contraception. Right? Now, in patients where the unprotected intercourse has occurred less than 96 hours and she's not in the 5 days of her ovulation. So the unprotected intercourse did not take place prior to 5 days of her ovulation. Okay, that's not 5 days before the ovulation. We want it very much before the ovulation for oral ECs, right? So if it is not there and her BMI needs to be checked, if it is more than 26 or it is more than 70 kg, then you know that you can start her with UPAC with contraception for 5 days and double dose of LNG, because for high BMI you require double dose with immediate quick start. But if she is a normal weight patient, in these patients, because they don't know, they are not in the period of ovulation, right? The ovulation might have already occurred. So in those cases, start her with LNG first with immediate QS and or UPA with quick start with with starting contraception after 5 days. Right? Understood? So if she is not in the first 5 days of her ovulation, in the previous 5 days of her ovulation, then if she is a normal weight patient, give her LNG first. And if she is a heavy weight patient, give her UPA first, because LNG you need to give double dose in this patient. Because she is not in the previous 5 days of her ovulation, the function of our oral EC to delay the ovulation is the motor of that is reduced, then it won't be much useful, and that is why give her LNG as the first option if she is a normal weight patient, right? And the only reason why we put UPA whenever the BMI is more than 26 is because we have to give otherwise double dose of LNG to this patient, right? Understood? Now, if the patient is having unprotected intercourse and she is come to you and she doesn't know whether it was less than 96 hours or not, then you need to check whether the unprotected intercourse was at least less than 120 hours or not, right? If it was not in the last 120 hours also, okay, so of course you know that for after 5 days of unprotected intercourse nothing works, neither oral EC, but we can see that uh, copper IUD, whether it was very much in the period of ovulation, so 5 days after the ovulation, you may still use copper IUD. Okay, so if it was not in the 5 days of unprotected intercourse, check whether it was in the 5 days of unprotected of ovulation, and then give her copper IUD. And immediate quick start contraception can be started if she doesn't want to go with copper IUD. But if you see that the patient has come to you, she is within the last 120 hours, but after 96 hours. So after 96 hours and within 120 hours, only one thing works, that is UPA, right? So give her UPA, because LNG is not working, is ineffective after 96 hours. So only UPA will work for her. You may reconsider copper T for her, because even that works for 5 days after unprotected intercourse or up to 5 days after ovulation. And in these patients, UPA and copper T can be useful. Okay, so that is how you can differentiate on what is the method of contraception that you will give to this patient. It looks a little confusing at the start, but try and go through it once or twice, maybe not on the same day, because if you don't understand on the very same day, then for the second time when you read it, you feel more confused. So if you read on the first day, try to analyze it and read and repeat it on the second day or one day after that, and then see your thoughts will get clear, and you'll remember these things. Okay, so that was your guideline. I hope that this video was useful to you. I know it for the start of any FSRH guideline, it looks a little difficult because of the interactions that can occur and the days that we need to remember. But you need to remember only the basics, only the important things, uh, like the contraindications where you cannot use certain type of ECs or any type of hormonal contraceptions, right? The places where you need to use double doses, all these things you need to remember. You need to remember the tables, you need to read the recommendations, okay? Apart from that, if you know the basics of all these things, then you'll be able to solve as many questions on contraceptive guidelines as much as possible. Do not worry that you'll get confused with FSRH guideline. It seems like that in the start, but once you revise it once or twice and you understand the concept, things really become very easy. So guys, this is me. Please subscribe the channel, because if you really find my videos useful, And if you subscribe the channel, it gives me a hint and a motivation that I need to keep on doing the same thing so as to help you. So please do it so that that will keep me giving you more free videos. And thank you for patiently listening to this guideline guide. Thank you very much.